episode of our webinar series, Confronting COVID-19. I'm Annalise Riles, and I'm the Executive Director of the Northwestern Buffett Institute for Global Affairs. So the COVID-19 pandemic has upended medical systems around the world, stressing emergency rooms and ICU units. But what about routine healthcare? Primary care systems are typically the point of first medical contact, delivering effective prevention and treatment, and over the past 50 years, contributing to significant reductions in death and suffering. Yet, our current global health crisis has produced major disruptions to frontline medical care. So how do pandemics impact healthcare more broadly, and how can we mitigate the most detrimental impacts? So to discuss this and more, I'm delighted to welcome a wonderfully global panel, two of my favorite Northwestern scholars who are just absolute role models of global engagement, and a colleague who can speak directly to some of the global dimensions of this question. So first we have Dr. Lisa Hirschhorn. Lisa is Professor of Medical Social Sciences and Psychiatry and Behavioral Sciences at Northwestern's Feinberg School of Medicine. Starting as a public health researcher and HIV clinician in the 1980s, her work has focused on understanding and improving disparities in quality and outcome of healthcare in the US and globally. Most recently, Lisa's projects have explored barriers to pre-exposure prophylaxis for HIV for women in Chicago, primary healthcare improvement in low and middle income settings, and people-centered healthcare and evaluation of quality improvement collaboratives in Africa. Second, we have Dr. Mark Huffman. So Mark is the Quentin Young Professor of Health Policy and Associate Professor of Preventative Medicine and Medicine Cardiology at Northwestern's Feinberg School of Medicine. He also directs the Center for Global Cardiovascular Health at Northwestern's Institute for Global Health. As a practicing cardiologist, researcher, and teacher, Mark works across the spectrum of cardiovascular disease prevention, aiming to improve global cardiovascular health and healthcare, particularly in low and middle income countries, and to bring lessons learned back home to the US. And Mark is also a member of the Northwestern Buffett Faculty Advisory Council. And I am especially delighted to welcome from Nigeria, Dr. Anthony Orji, who works in the Cardiovascular Research Unit of the University of Abuja Teaching Hospital. His research focuses on hypertension and associated risk factors in rural communities, and Tony has collaborated extensively with Mark, Lisa, and other colleagues on a project to transform hypertension control in 50 primary health centers in Nigeria. So we're delighted to have all three of you. Looking forward to your comments. Welcome. And Lisa, I'll turn it over to you first, I guess.
Great, thank you so much. And I will share my screen. Great. So thank you all very much for taking the time to join us virtually in understanding about pandemics and primary healthcare resilience and why this matters now as well as in the future. So many thanks, because this takes a village, for the work that I'm doing. A number of these slides come directly from a USAID-funded Momentum Knowledge Accelerator project with work done by Emily Stamler, Catherine Semmer, and Lara Vaz, as well as learnings from the University of Global Health Equity and Under 5 Mortality Exemplars team, as well as the hypertension team, and some of this work from Northwestern Institute Global Health Catalyzer funding. So the first question is sort of, why should we be worried? And, you know, many low and middle income countries have successfully dropped mortality due to expanding effective, equitable primary care. It's been a long haul since Alma Ata in 1978, but we're actually getting there. But we also know that drops in primary care were seen earlier and in ongoing health-related shocks, Ebola being the one that's most clearly documented, but cholera as well as Zika. And disturbingly, we'll talk a little bit about this more, that even very early in the COVID-19 pandemic, we began to see drops in use and access in primary care in the US and other high-income countries, as well as in low and middle-income countries. So what did we learn from the past? Well, what we saw in Ebola was we saw a drop anywhere from about 1/4 to 2/3 in critical services, such as family planning provision, compared to the pre-outbreak period. And largest decreases were seen in the provision of implants, which require personal protective equipment and direct contact. So again, a warning of what may be coming. During Ebola, we also saw a decrease in institutional delivery. These were in countries, in low and middle income countries where maternal and under 5 mortality is still a major problem. And similarly, intermittent preventive treatment of malaria, which is a very significant infection if gotten during pregnancy. We saw a decrease in facility-based malnutrition screening for children, and we saw an increase in malnutrition diagnoses once those children actually were brought in for care. And it was estimated that there was a miscapture of many common illnesses that cause a tremendous amount of morbidity and mortality. About 74,000 fewer malaria cases were seen in health facilities in Guinea during the Ebola outbreak. Now, this impact was both because of decreases in demand as well as supply. There was distrust of the government and healthcare workers, which discouraged health seeking. People had a tremendous fear, and not only that, but with good reason, and again, what we're seeing in COVID, there was healthcare workers and facilities feared nosocomial infection due to reduced availability, quality of their PPE, as well as community trust. We saw community health workers stopping delivering care because of fear of being infected or of them being actually reoriented, so they stopped doing primary care to do things like contact tracing, as well as directives to actually stop providing care by partners who were actually worried that they might get infected. We did, however, know that if you have government-organized community health workers, so really these embedded workers, that actually predicted some sustainability of health services, but that as the distrust of healthcare workers grew, reliance on community-level practitioners, traditional healers, traditional birth attendants from maternal and child services was growing. Now, we also know that there's no one-size-fits-all and that the context matters. So the nature of the outbreak influences the response that's needed. Ebola needed new intervention needs along with existing service disruptions. Zika was actually less disruptive, but really needed an adaptation of existing service delivery based on emerging needs. There's tremendous increase in desire, for example, family planning, as well as some new interventions to provide care for the children who'd been affected by Zika. Now, we also know that the barriers and the impact varied based on the location and disease. For example, in Liberia, urban, you had problems with facility closures and healthcare workers refusing to see patients, as well as the community fear of contracting Ebola in the facility. In rural, they also had the same fear, but actually more of it was actually reduced care seeking as opposed to the lack of service availability. We also know that the higher level of exposure negatively correlated with trust and care seeking. So those were communities that needed more work. So what are some of the lessons that emerge from there that we can actually learn from? Well, one of them is about this concept of resiliency. And the idea is a resilient health system is one that provides good care in good times and in bad, so not just in bad times, and it has to be good care. And that there's sort of 5 major characteristics that were described by Margaret Cruck and her colleagues, that it had to be integrated, had to coordinate with some of the non-health-related actors, that had to engage citizens and communities to build trust, again, reflecting what we learned in Ebola. It had to be adaptive. It had to be able to shift resources to meet the needs and promote rapid local decision-making, and it had to be able to evaluate to improve its change, and as we see in COVID, also the phase of the epidemic. It had to be aware, had to know its health system capacity, but also the burden of disease and the risks in the populations, and communicate that. It had to be diverse, so it had to effectively respond to a range of health needs, not just the epidemic, but issues around ongoing healthcare needs, and adequately finance that. And finally, it had to be self-regulating. So it had to be able to maintain that core function, which is what we're really focusing on today, what we're calling the response to the COVID-19 response. How do we actually make sure that the drop that we saw in Ebola and the resulting deaths are not happening? So the problem is there's obviously already these early warnings of the COVID-19 impact and readiness. There's some modeling that's been done using the live save tools, which estimates anywhere between a 9 to 44.7% increase in under 5 child deaths per month, and similarly increases in maternal deaths. And we know that the facilities are not ready to safely provide the needed primary health care. In India, we've seen issues around limited physical space and queuing capacity, inadequate ventilation. Only half of them had any N95 masks. And they've already started to report the PHC has been significantly disrupted with non-communicable disease visits going down from 92% readiness to 41%, and vaccination coverage dropping as well. And this is even worse in low-income countries. Now, going to one of my usual now sources of medical information, the New York Times, we're also seeing issues around measles outbreaks, diphtheria that's appearing in Pakistan, Bangladesh, and Nepal, cholera in South Sudan and Cameroon, but adaptations are already underway. You can see on the bottom right, MSF is delivering vaccines, and similarly some guidance that we're beginning to see on maintaining essential health services from the World Health Organization. So what can we learn from the past and what do we need to do? We must focus on maintaining life-saving preventative and curative services. We have to adapt our delivery models, and it has to be integrated. We need to recognize and engage the communities as essential partners in maintaining the services. We need to monitor what's working and what's not and be aware, and always to remember equity. So who is being left behind, who's not being served, whether it's direct COVID care or ongoing primary care. And we need to use data and other evidence to inform these adaptations. It's a clear role for what's been recommended from UNFPA to embedding implementation research to very rapidly identify and learn from and spread, and equally importantly, to adapt or abandon ineffective strategies and solutions. So in order to do this, we really need to do three major things. We need to prevent the decline from happening. When it starts to happen, we need to work to detect and mitigate these decreases when they start. We need to understand why they're happening. We need to adapt to prevent that. And then we need to respond if these drops in services continue, whether it's in coverage, but also if it's in equity and very importantly in quality that are already occurring. So one approach to thinking about this is actually thinking about this in the broader concept of primary care. And there's increasing evidence about the role of primary care in both the COVID response as well as in preventing drops in life-saving interventions. This is a framework that's been widely used, developed in the Primary Healthcare Performance Initiative, a large initiative funded by the Bill and Melinda Gates Foundation, which includes the World Health Organization, the World Bank, as well as Ariadne Labs and R4D, something that I've been involved in since the very beginning. And the idea is that you really need to have this broad platform on which we need to think about strengthening primary health care to withstand the current and future pandemics. Some very relevant areas for resiliency include things like financing. How much do they spend on primary health care? Is it actually adequately financed? Do you have the capacity to, again, deliver good care in now and in the future? Do you deliver primary care that meets the people's health needs? And very critically, equity. Does your primary health care system effectively serve the most marginalized and disadvantaged groups in society? So I'm now going to turn this over to my colleague, Tony, who's really going to speak about what's happening and what's some of the work to improve hypertension care before, during, and after the pandemic. Tony?
Oh, thank you, Lisa, and thank you, audience, for being there. Talking about primary health care in Nigeria, I want to give you a bit of a background. Nigeria is the most populous Black nation on earth. About 191 million people with life expectancy of 55 years, and half of its population living in extreme poverty. With this context and other factors, we can understand why we are having this poor health indices. Financing of healthcare system, about $51 per capita, on health work capacity, 0.4. Community health workers by 1,000 population, 1.5 nurses per 1,000 population, 0.4 physicians per 1,000 population. And when you're looking at, again, the costs of healthcare, 42% are not able to access adequate healthcare because of cost, but 29% not able to access adequate healthcare because of distance. And you can see inequity as evidenced by under 5 mortality rates of 1,000 bags. Next. Fine. We want to talk about hypertension treatment in Nigeria. Why? Why HTN in Nigeria? Because of the unmet burden of hypertension in Nigeria. A 2013 report demonstrated the prevalence of hypertension of 44.9% among Nigerian adults who are above 40 years. A 2015 systematic review and meta-analysis of 7 studies revealed a prevalence of 28.9% in adult Nigerians. Looking at, you can see that it's a huge public health burden. Yet, the awareness is still very poor, 14 to 30%. Treatments for less than 20%. And the control rate is even worse, 9%. Next. So that is the essence of hypertension treatment in Nigeria project. It's a primary care-based hypertension program, which is based on the KPNC hypertension model, which has been shown to increase control rates from 44% to 90% between 2000 and 2013. It has 5 components: patient empowerment, use of simplified protocols, use of fixed dose combinations, task sharing and task shifting, and a robust audit and feedback mechanism. This same KZAT model serves the basis for WHO HAS package in 2016, as well as the Resolve to Save Lives Global Hypertension Program of 2017. And that is what basis we are using in this HCM project in Nigeria. And still, community intervention to reduce cardiovascular diseases in Chicago, still based on this program. Next. What are we doing in our HCM project? Is a large-scale project targeted 50,000 participants, a 5-year study that aims to improve the awareness, the treatment, and control rates of hypertension in public practice in the Federal Capital Territory of Nigeria. It's a program that is in partnership with Abuja University and Northwestern University in Chicago. In this study, the team is adapting and implementing and evaluating both the effectiveness as well as the implementation of a system-level hypertension control program. Next. The picture you are seeing is HDN in action. On my left-hand side is an on-site training of healthcare worker on blood pressure measurement. This was a pre-COVID experience. And on the center is electronic data capturing training on site. It's still a pre-COVID experience. And on my right, you could see training going on during the COVID era with physical distancing being maintained, with nose mask, PPE, and hand sanitizer. Next. So in this program, what did we do? We use World Health Organization Service Availability and Readiness Assessment tool to focus on hypertension. We're able to make our assessments based on the staffing levels, availability of key steps in hypertension treatment cascade, the equipment and supplies for hypertension management, the information system infrastructure, and as also the availability of blood pressure lowering medications in these PHCs. Next. We used a multi-state sampling frame to select 60 PHCs across the 6 area councils of Federal Capital Territory in Nigeria. We excluded the wards with security issues, as well as the wards with access issues, and the facilities with low staff. But we tried to maintain geographic representation. That is why we use 1 site per ward, including with the Nigerian Primary Healthcare Board Basic Healthcare Provision Fund program. We also did sampling based on population density with additional sites selected in the area councils with greater population density, like Abuja Municipal Area Council, Bokwada Area Council, and Kuje Area Council. Next. This is the map of Abuja, Federal Capital Territory, Nigeria. When you look at the map, you will see the dots. The yellow dots are the facilities that has both the Primary Healthcare Board program and also a focal person of the ward. A focal person is the head of all the PHCs within a ward. So the facilities that has these programs and this person in on site, we are also giving priority, and that is why you see the yellow dots. Now the blue dots are the primary healthcare basic facilities only, and the dark dots are the focal person only. Why the green dots are the facilities that don't have any of these programs. So what you are seeing scattered there are all the facilities that were selected, and you could see the presentation as mentioned earlier. Next. So what was our results? At the personnel level, we found that almost all the PHCs have full-time health professionals, which are predominantly community health extension workers and nurses, and the ratio of 3:1. We noted that most of the facilities had capacity to screen and blood pressure. And also more than half of the PHCs were able to dispense BP-lowering medicines and monitor patients with high blood pressure over time. We also looked at availability of information and education materials, availability of treatment algorithms for hypertension, and guidelines for hypertension treatment. We discovered that they were not available in most of the PHCs assessed. Next. So on the medicines and medicines logistics, half of the PHCs hypertension medicine are available and valid. And most of them have 30-day dose of hypertension medicines in stock or dispensed in the last 30 days. And about half of the PHCs obtain their medicines from private sources, while most of the sites have to arrange medicine delivery to their facility. Next. Next, please. Good. Now, looking at the table, you could see the disruption of facility attendance and outpatient attendance over the months during COVID. You could see the drop as before pre-COVID, January and February, and you could see the drop in March, April, and May. So it showed clearly that the disruption that came at facility levels during COVID. Next. Even with that, we still notice that the overall recruitment has not slowed in HCM program, though the pace has been uneven across sites. It has shown some resilience, I could see in the graph. And we also noted that hypertension treatment rates at baseline remain 60%, and the control rates is almost 20%. Next. So, primary care resilience in Nigeria. We noted that hypertension treatment in Nigeria projects recruitment has been ongoing despite COVID. We have empaneled about 2,200 patients from 60 facilities. And this was possible by reason of clinical design, whereby more spaces were created, more chairs were provided, physical distances were maintained, PPE were being used, hand sanitizers and hand washing facilities were provided. And patients were meant not to crowd in the facility. They were attended one at a time, and they lived to be able not to crowd the place. So this were introduced to be able to continue delivering PHC services in Nigeria. And health worker training was still ongoing, just like you saw in the earlier slide. We maintain physical distancing in our training. We use PPE, we use hand sanitizers to make sure that the training continued. And our team will also evaluate SARS-CoV-2 seroprevalence among healthcare workers using the dry blood spot-based assay developed by a Northwestern research team led by Professor Thomas McDaddy. Here in the slide, you see our co-PI in Nigeria, University of Abuja, Dr. Orji and Professor Thomas McDaddy. of Northwestern University. Next. Yeah. Right. Thank you. As I invite our colleague, Dr. Mark, to continue from here. Thank you for listening. Mark, over.
Thank you very much, Tony. Next slide, please. So within the context of the COVID pandemic, we've been working very hard to maintain clinical care across primary care facilities, not just in Abuja, the Federal Capital Territory of Nigeria, but also in Chicago, but also in Delhi and all over the world. So Resolve to Save Lives is a large nonprofit that is led by Tom Frieden, the former director of the Centers for Disease Control and Prevention. And they've assembled an adaptation guide or framework for thinking about adapting hypertension programs to COVID. And when I think about these, I don't just think about what we're doing with Tony and his team at the University of Abuja, but I do think about also what's happening in my own clinical practice here at Northwestern. So for example, if COVID cases are presenting to a PHC, that first point of contact challenges COVID exposure to other patients, but also COVID exposures to healthcare workers. And so what's needed is primary health center redesign. So what are strategies that allow for physical distancing when people are queuing up? So Lisa had described some of those challenges in India. If you go to Northwestern clinics, there's far fewer chairs than there were before, but there needs to be greater investments in redesign to protect patients as the pandemic ebbs and flows. We also have one around lockdowns and travel bans. Something that we've all faced as we're doing a lot of this type of activity. And so people can miss their clinic visits, they can miss their medicines because they can't get them. So I've been practicing a lot of telemedicine over the past several months, community outreach, making sure that patients have things like food, medicine, supplies, what needs to be delivered to them if they're not able to not only come to clinic, but go to other key service points. In many low and middle income countries, 30-day medicine supplies is normative, and that's used as a strategy to retain patients in care, but that's actually a double-edged sword because it leaves for greater opportunities for people to stop their medicine. So 90-day medicine supplies are actually a system or policy level strategy that improves adherence and improves control rates. And then you saw those motorbikes that Lisa had shown for community medicine delivery through MSF. A third COVID situation is the expected waxing and waning of the epidemic. And so within resilient systems, we're trying to think about preventing discontinuity of essential services. How do we prevent people not just from missing out on their medicines, but also missing out on care that could result from missing out on their medicines, such as heart attack and stroke care. We're concerned about losses to follow-up in our clinical practice and missing research data. So we need to have a resilient research team to be able to collect high quality data. We need to be flexible in our design for the program, clinical program, as well as the research program. So next slide, please. So I wanted to give you some examples of primary care resilience, both in Chicago. We've talked a little bit about what's happening in Abuja. And so here at Northwestern, Dr. Gail Crickey and Dr. Jeffrey Lindner have developed the outpatient COVID monitoring program through Northwestern. This paper was published a couple of weeks ago. And the figure on the left shows the time on the x-axis from late March to mid-May. And on the y-axis is the number of participants or patients who were part of this COVID program. And essentially, many people can get COVID but not get acutely ill. But these people still need monitoring. So the Northwestern team rolled out this program that was initially led by medical students and nurses with oversight from attending physicians, such as myself, to call patients on a daily basis through the time period where we would expect them to potentially develop worsening symptoms. So perhaps their testing was early in their symptomatology and they could be cared for at home. But over time, some of these patients did deteriorate and needed to be followed up regularly and directed for acute medical care. So when we think about that engagement, this was a good example. And I put on the right-hand side of the slide really those domains of health system resiliency that Margaret Kruk and colleagues had developed. So we think about, is this integrated within the primary care setting? Definitely, because these are not only the patients seen at Northwestern, but the clinical team taking care of them. It has readily adapted to this completely new problem that wasn't there not that long ago. The team was aware of the issue, and this was something that patients were asking for and needing, as demonstrated by the number of people who participated in the program, over 7,000 over the entirety of the program through mid-May. It's diverse, meaning this is a different type of way of practicing by having medical students calling people with a structured script and then going up the chain to nurses, doctors as needed. And self-regulating, meaning that over time, the physicians didn't play much of a role at all in this. This was largely driven by the nurses and students. So it was a great example of what's happening at Northwestern for primary care resilience. So again, as Lisa had mentioned, and at least bringing these ideas that we learn from places like Abuja back to Chicago. Next slide, please. I also wanted to share some work that we do with the Access Community Health Network in Chicago. This is the largest network of federally qualified health centers in the greater Chicagoland area. This health facility, we do a randomized trial on a 4-in-1 combination for blood pressure lowering to try and simplify blood pressure treatment. And our research activities have had to stop outside of remote research activities because initially patients weren't coming in for primary care. There was disruption in that care. But I'm proud to be able to share that Access has really launched its COVID testing. You can see the staff at one of the sites where we do research for this clinical trial called Quartet, the Ashland site on the south side of Chicago, ready to go with testing their patients who are coming in. You can see there's been about 4,500 or so test orders with 640 COVID cases identified, with some that are still pending. You see some other variables throughout the infographic, but on the bottom right part of that, I want you to see the distribution all throughout Chicago. So this is in the fabric of Chicago primary care, and particularly those individuals who might be more vulnerable or be low income or have difficulty paying for their services. Access provides an important network for them to be able to receive their primary care while also being able to receive testing for COVID. Next slide, please. So within Buffett, one of the central organizing principles is around the Sustainable Development Goals. And to remind the audience that the UN Sustainable Development Goal number 3 is to ensure healthy lives and promote well-being for all at all ages. And in the context of a pandemic, we have an opportunity to create a new and future plans to achieve some of these global goals. And the foundation of SDG number 3 is target 3.8, including universal health coverage, including financial risk protection, access to quality essential healthcare services, and access to safe, effective, quality, and affordable essential medicines and vaccines for all. Annalise mentioned that I'm lucky to have the Young Professorship. This is named after Quentin Young, a legendary physician here in Chicago who had fought for universal health coverage for decades before it was ever popularized by the Medicare for All slogan. And universal health coverage will not be achieved without strong primary care. So these two go hand in hand. When we hear things about free access to COVID testing or COVID-related treatment, we have to get rid of the COVID piece of it. We do need to have universal health coverage to achieve healthy lives and promote well-being for all at all ages. Target 3.D also includes strengthening the capacity of all countries, and particularly developing countries, for early warning, risk reduction, and management of national and global health risks. And what bigger, more in-your-face problem have we ever had in my lifetime than COVID? And this figure that we see by Beery and colleagues in the Corona Sustainability Compass thinks about the coronavirus crisis at a crossroads and trying to think across different domains about where were we and where are we going to go. So for example, in the socially just economy, how do we create an economy in which nobody is left behind, much like as we think about in universal health coverage? from a concept of disgorgement logic, where there's an externalization of social and ecological costs, where those are just not part of the value proposition that companies and other industries will be arguing for, versus in the future, will we internalize and value the social and ecologic dimensions that are part of companies? This relates very closely to global environmental change. So thinking about from yesterday to tomorrow, how do we approach the insidious yet existential threat of global environmental change? Do we wait for the consequences until it's too late? Or do we reshape the relationship between people and nature and the economy, towns and cities, nutritional systems, something important to me, and energy systems? Next slide, please. This concept of the role in science, boy, it feels super topical when we think about the different screening methodologies, the effectiveness of pharmacotherapy, of masks, and the politicization of that. What is the role of science in resolving the global pandemic? Are experts with words of warning alongside doubters and fake news? Can we separate these two in terms of who we trust fundamentally? Or decision makers in the world of science jointly developing solutions? We hope that it's more of the latter than the former, but we're in a pretty important time in our history to think about how do we go from a period where whether you wear a mask or not seems to reflect your politics rather than your interest in being healthy. So there's obviously lots of other issues in the area of sustainable development that coronavirus is starting to uncover and make us think a lot about the foundational pieces of this. So they give examples related to prosperity, happiness, participation. What is our intergenerational contract, our social relationships, and security? Next slide, please. So in conclusion, we've talked a lot about pandemics and primary care today. I'm so grateful for Lisa and Tony to join me in this. And in summary, equitable expansion of quality primary care has been central to improving health and healthcare in many parts of the world, including Nigeria, over the past several decades, and will continue to be central in the future. Pandemics often decrease access, trust, and provision of primary care services. Effective contextualized responses need to be based on root causes, geography, as well as the pandemic response itself. Third, resilience in primary care is needed to prevent or mitigate impact not only during pandemics, but also before and after them. Think about if any of you have a primary care doctor, hopefully you do. If you've had to contact your primary care doctor during the COVID pandemic, it's been pretty different. And trying to think about when it's easier for you, you sense that resilience, you live that resilience. And for those of you who are primary care doctors, you know that it's taken a lot of work to be resilient in this time. And some of your patients are able to be resilient with you. Other people need a lot more than what you typically offer. So it's not a one-size-fits-all approach, including during the pandemic. And resilient research teams need broad, deep, and sustained stakeholder engagement for transdisciplinary research ideas to be developed, contextualized, implemented, tested, disseminated, and scaled anytime, and especially during pandemics. And with that, I'd like to thank you all for your time and attention, and I know we look forward to your questions.
Well, thank you all so much. You've given us so much to think about. This is fantastic. Oops, let's get there. There we go. So much to think about here. Maybe I'll just start things off, but let me say that if you have questions, please just put them in the chat and I will pose them to our speakers. So listening to you all, and Lisa gave us those wonderful graphics and sort of a vocabulary to think about this question with, and then Mark and Tony both gave us some really wonderful examples and data to think with. So let me just ask Mark and Tony if you could comment on what you're describing in light of Lisa's framework. So Lisa talked about resilience and equitable care as really critical. It sounds like you're both describing, both in the Nigeria case and in the Chicago case, that our primary care systems were relatively resilient and relatively equitable, that we've done pretty well in this crisis. Is that correct? And my second question would be, if you had to say, look a crystal ball looking ahead 5 years, How do you think that the entire field of primary care will be changed, if at all, by having gone through this crisis?
Tony, you want to go first?
All right, thank you, Annalise, for the question. Yeah, concerning the resilience in the primary healthcare system, yes, we could see some level of resilience. Like what we saw in Nigeria. Despite the COVID, there were systems that were redesigned, and efforts were being made to train. In fact, it's not just at the primary care level, even at the national level, because the primary care is being overseen by the National Primary Care Development Agency, and who rolled out, the new primary health care with respect to responding to the COVID pandemics. So these guidelines were cascaded down to the states, who now pushed it down to the LOGS. So the LOGS now had to implement. So there were a lot of modifications that came in, being able to expand the spaces, being able to maintain physical distancing, and then making sure that PEP is used both by the patients, for instance, face masks, and also by the staff being protected. So with this, a lot of confidence came back, both in the minds of the healthcare workers who continue to go to work to render these services, and also in the patients who continue to come to access the service. So it really shows some kind of resilience. And though we know we are not, but with what is already on ground, we're going to continue to improve, and we're going to see more improvement over time. Thank you.
Thanks. And maybe I'll follow up on that. It's pretty early days, Annalise, in terms of the data that we have in hand. And I feel like there's a longstanding history of inequities hiding in the shadows. And so the data that we have may look pretty good, but these are also not maybe as comprehensive as we'll need to be to really have a whole look at how primary care in Chicago, for example. There's obviously a long history and this current experience of vulnerable groups being disproportionately affected by COVID. And so I fear that there will be differences in access. My own clinical experience in taking care of patients, there are some people with whom I can have a video visit or a telephonic visit, and it's really great. It's almost seamless. And then other people, patient I spoke with yesterday, just real simple things of working through her medication list. This was a real struggle over the phone. That I know that when we've done this face-to-face, we can go through those things. So I think we're still in the early days. I'm hopeful that we can become a more resilient primary care system in Chicago and more broadly. But I think, like other fields, much of the focus in primary care in the United States has been about turning, relative value units, like seeing patients through the system, instead of thinking about the resiliency of that system to be able to manage the patients who do need more support. How do we build that in and incentivize the care of these sickest and sometimes most marginalized patients?
So Lisa, do you have any views on this, listening to these two examples in light of your framework? Any evaluation of what you're seeing?
Yeah, I think, it's been hopeful, because as opposed to with Ebola, this didn't happen until 2 or 3 years after the epidemic. It was like, oh, what happened to all those women who didn't deliver and those children who died? So I think I think this is definitely more aware. I think we are seeing areas of recognition that often people's medical problems, which are challenging as it is, that often they're now being completely overshadowed by a lot of the socioeconomic challenges they're going through, whether it's access to food, whether it's trying to develop childcare, whether it's dealing with COVID themselves. So I think we are getting there. I think we have a long way to go. It was interesting to watch how quickly or how slowly, for example, certain insurers were reimbursing for televisits as a means, again, of an adaptable system that was absolutely critical. Thinking about the settings in which I'm doing a lot of my work, for example, in Liberia, televisits are not possible because we actually have no phone coverage, and most people don't have cell phones in the very rural areas. But on the other hand, we have a very strong community health worker program that, with proper PPE and adaptation of how they're delivering care, for example, no touch, are still able to continue to provide a number of the key essential things: integrated management of childhood illness, for malaria treatment, et cetera. The vaccination's been more of a challenge because that's more of a system issue. So I think part of it is, how are we ready? So we've never invested in the U.S. in these community health workers. They've been done in certain places, in the Bronx and a couple of other places. So instead of us having to hire and train thousands and thousands of contact tracers, we could have actually had a robust, resilient system that's able to respond to these types of community needs and community outbreaks. So I think we're getting there, but I still think we have a lot to learn bi-directionally.
Interesting. So we have a question from our own Dr. Ariel Schwartz, who asks about the importance of trust. So, Mark, you pointed out that we seem to be in a world in which science is very politicized, and Lisa, you just described what sounds like a quite wonderful set of innovations in certain communities in which local healthcare workers have closer relationships and presumably different kind of trust relationships with the experts. How important is trust in these moments? What are you seeing in how trust is changing? What can we do to build trust in the primary healthcare system in times of high stress?
I'm happy to take the first crack at it. So I think it sort of, there's within the primary healthcare system, and then there's the more sort of global role of science and trust, or now sort of distrust of science, which is, I think, a huge threat in many, many ways, of which we own some of that responsibility in our inability to communicate well to communities about what science is and what it isn't. In terms of primary care, the World Health Organization has come up with this concept of integrated people-centered healthcare. And it takes primary health care, and it says primary care, which is the medical services that we typically do, is one part of it. But that the other parts, and again, reflecting the SDGs, have to focus on some of the other threats that are associated with people. So I think as we start to think about that, putting the patient in the center and understanding what their challenges are and what their priorities are, that will then build the trust that's needed. It's really been very much associated with how we communicate, their confidence in the system, their trust that their needs will be, that they'll be listened to and their needs will be met. So I think we're evolving towards it, but I think that's critical. And again, being able to have people in the community, from the community, who are part of the official healthcare system. So these healthcare workers in Ethiopia and Rwanda and Liberia, they are not volunteers. They are salaried, they are supervised, they are paid. And that in and of itself has been associated with a greater trust in the system. And they are not just delivering all the care, but they're also making sure that people are coming in for care when they need it, for facility-based deliveries, for hypertension, for other areas where I think the continuity and trust is so critical.
And to follow up, I mean, I've learned a lot from Lisa about measuring experiential quality. It's something that we do. I get evaluated by my patients in Chicago all the time. You go check on how it is. And one of the most important measures internally at Northwestern is likelihood to recommend, meaning, do you trust the doctor that you're with enough to recommend to another person? And that's infrequently measured in other parts of the world. What is the value that's seen from the patient's perspective? Because the doctor can feel like, well, I'm so busy, I see so many patients, and therefore people must trust me. But if there's such a high volume of people that the number of people who divert or go to a different physician or choose not to show up to that facility, that can be a demonstration of distrust. I mean, like so many things that people do, medicine is fundamentally about trust. You're sharing some of your most private information that's so sensitive to you, to a physician. It's a social enterprise. It is not just a technical, do you have the answer right? People go for healing, not just for numbers and answers. And if that person rejects you, or you feel rejected by that person, then that can, the whole the whole enterprise can just fall apart very, very quickly. Very quickly. So it takes a long time to build that up. And like many of the other people who are on the audience and the work that they do, and it can go away just like that. But if you don't ask people repeatedly, you're not going to be able to know how best to improve that trust, because you don't know where the distrust might be necessarily coming from. There's definitely macro models of where it could be around access and time and quality and things like that. But I think fundamentally, as Lisa's taught me, asking people, that's a good way to start.
So Dr. Orji, we have a question from the audience for you about following on Lisa's point about telemedicine not being appropriate everywhere. Can you tell us, telemedicine feasible in Nigeria? What kinds of technologies, mobile technologies are available, and what kinds of innovations are appropriate?
Okay. Well, thank you, Annalise. Telemedicine is on its stage in Nigeria. There are a few pilots going on here and there, and we hope that's going to still improve and get better. You know, the one aspect of using a remote computer and a screen to train and teach healthcare workers, you know, is one aspect that is going on. And the other one could be using telecommunication to link patients to physicians, you know, and then possibly to get a consultation with a physician or to refer to another facility. So it's still on the bottom stage, it's ongoing, and we feel it's a field that is very promising. You know, putting the right facilities in place and with the full government and political will, we think that it can fly in Nigeria, at least to a large extent.
Tony, do the patients have access to the technology they need to participate? In other words, cell phone technology is wide enough spread that they could use cell phones?
Yeah. The cell phone is actually widespread, and that is working very, very well. You know, some patients have been, there are some aspects that they give periodic education. You know, for instance, maybe hypertension in pregnancy, you know, they can give them some information, or pregnant women, they can give some information through the tele, you know, and from time to time covering different topics. So in that way, they receive the alerts in their phone and they read through and they learn. So using cell phone is one aspect that can sell well and then be able to have a far, especially in the communities where you don't have the computers and they're not readily available, but the cell phones are widely available. Yeah.
Thank you.
You know, Lisa, I think there are a couple different models of telehealth. So oftentimes we think about the patient to doctor model, but there's also the doctor to doctor, healthcare worker to healthcare worker model, or a knowledge network. And we're very interested in our team of trying to embed that within our existing HTN program. Abby Baldridge is leading that. She's works in the Department of Preventive Medicine as Assistant Director for Research in the center. I think the reason why we're more interested in the knowledge network piece of that is because we think that that will be more likely to reduce inequities versus the technologically based virtual visit is probably more likely to widen inequities, because you're going to improve access for people who do have that technology. And so trying to think about not all telehealth is the same, essentially.
Very interesting. So maybe along that line, Lisa, a question for you from one of our audience members about the place of hospitals in state-of-the-art thinking. So as we think about more resilient systems of primary care, especially in crisis situations like pandemics, do we want a system in which we've really decentralized and as few people as possible are in hospitals? Or what is the vision of what's the role for the hospital versus the outpatient in the state of the art?
No, that's a really, really important question. And I think there was a lot of discussion going on even before that, which had to do, there's a big controversy right now about where women should be delivering. So in the US, you're supposed to deliver in place where there's higher volume, et cetera, et cetera. Well, and there's something called CMOC, which is comprehensive obstetrical care, which means that you have access to cesarean sections and blood transfusions as opposed to a trained delivery. Now, it doesn't happen very often, but you do, when you need it quickly. And so there's a big controversy about what should be decentralized. So the bottom line is that we should still have to focus on primary care. So it's the 4 C's that Barbara Starfield talked about, which is it should be first contact. It's where you go for your first contact. It should be comprehensive. It should be coordinated. It should be continuous. And the 5th C is it should be patient-centered. Now, that's critical for the vast majority of things that people need to be seen, and it needs to be embedded within a tiered system so that people are getting the care they need where they need it. So we know from past experience that if you don't have that and people bypass primary care, they're more likely to show up with their diabetes needing their leg amputated, they're more likely to show up with their heart attack, et cetera. Now, when something like COVID happens, it's a little bit different than Ebola. So Ebola needed high-level care for everybody. And what's interesting about COVID is that there's sort of 3 groups of people. There's people who are going to get it, may not even know they have it, and be pretty well. There's going to be people who are going to get it, who need to sort of who are not sick enough to go to the hospital but stay at home, which was the data that Mark was sharing. And then there's the people who really need the hospitals. And so I think the answer is it needs to be all of these, but if we put all of our COVID money into ventilators, in a lot of these countries, many, many more people are going to die. They're going to die from their heart attacks because they're not getting their hypertension medicine. They're going to die in childbirth. They're going to die of malaria, et cetera. So we need to balance that. And we also need to understand what is appropriate for the context. So bringing ventilators into a country which has no oxygen plant, has no ability to actually continue that, is not necessarily the best use of hospitals. And I think that we need to continue to focus on primary care, but we need to do that within a network so that those providers feel supported, perhaps through this telemedicine, to know when they need to refer people and that they have a place to which they can refer them.
Interesting. So maybe I'll just close by coming back to Mark's wonderful provocation that we might be at a crossroads. We could go different ways at this moment. It could come out different ways. And I'd like to ask you all to close by reflecting on the economics of primary care. So I was fascinated that you mentioned that it took a while for insurance companies to come around to telemedicine. Do you think that we are seeing any change? You talked, I think, Mark, you also talked about time, the fact that you have to mill people through the system and that there isn't time to spend with the people who need with it the most. Do you think we're facing a moment where we might see some change in that economic system such that things would go in a more positive direction? Or do you think that really at the end of the day, a business is a business and the machine just rolls on and we're not going to see change?
I think until we in the United States treat health as a human right and not as a commodity, then there will be different iterations of what it is, but it will be a business enterprise. But I do think things around what is the healthcare right now. I think those discussions are top of the political discussions, right? And so that it's exciting to think that things could change. The acceptability and readiness of telemedicine flipped very quickly because of payment related to it. So it offers tons of opportunities that we can learn from what Tony and his team, they know how to do stuff like contact tracing. Whereas us in the US, what is contact tracing? It's a brand new thing. And so there's so much to be learned about that. But in primary care, think about task shifting. There's plenty of patients who, I try and talk, if you might be able to talk to the nurse about it, and they say, no, I want to be with you, the specialist. And you're sort of this isn't great when the system sort of has that as its approach. So I would hope that we can take advantage of it, but until health is a human right, it's going to be more of the same.
Anybody else? Can't hear you, Lisa.
Just echoing that it's true that as soon as we continue to put a price tag on things and sort of say, well, what's the most efficient as opposed to what's the most effective, what's the most equitable, what's the most quality, what's the most acceptable, I think this will be a big challenge. I think what's going to surprise people is the excitement of a lot of patients and providers for telemedicine. And so if there's a way of making it that is not just sort of a good way of reaching out, that we're making sure that it's equitable, some work that I'm doing with Claudia Hawkins about who actually is able to do telemedicine from the patient perspective, but also one in which is found to be much more efficient and much more cost effective, then I think we stand a chance. But again, you'll notice I brought the word cost into that 3 or 4 times, again, reflecting back on what Mark said.
Yeah.
Orji, I'd like to give you the last word. Any thoughts on this? The economics of healthcare? Well, we can't hear you.
Okay. Oh, great. Thank you. I am thinking that telemedicine, has its own place, with the way the world is going. So what I'm thinking is that it has to be adapted to the context of the community or the society where it's being practiced. There are some model of telemedicine that might work in Chicago, but will not be able to work in a rural community in Abuja. So we had to look at our context and see which model will be able to benefit us and which model will be able to be cost effective, which the patients afford or the government supports. So in that way, when we sit down and look at that, we'll be able to choose. And then when that is done, I think that telemedicine will be something that will fly. Thank you.
Thank you. Well, thank you so much, Mark and Tony, for being here today, for the wonderful work you do, and for enlightening us on many of these issues. And thank you to everyone for participating. Next week, next Tuesday, is actually our last session in this webinar series. It will focus on incarceration, criminality, and COVID-19. So hope to see you then. Until then, everyone, be well. Thanks so much. Bye.
Thank you.